We're going to go ahead and get started now. I'd like to introduce sorry, I was awake a little too late last night. Dr. Coker, and she is a graduate from the University of Tennessee. She is also an assistant professor with physical therapy department at Tennessee State University, where her areas of interest include adult neurology, pediatrics, prosthetics, orthotics, acute care, and interpulmonary systems.
Yeah.
Dr. Coker is a Nashville district chair of the Tennessee Physical Therapy Association, and she loves playing with her grandchildren and participating in community 5Ks and half marathons. Go ahead, go ahead.
Thank you. Thank you so much. Thank you so much for letting us come today. And we've got OT, PT, and speech for you this morning because we work as a team so much that it just makes sense for us all to be in the same room speaking at the same time. And so I'm going to start on the physical therapy aspect of it and roll through some slides for you. Maybe. I don't know, Missy.
It's not. Mm-mm.
There we go.
Oh, okay.
Yeah. Sorry. Let's get started. So mitochondrial myopathy, some of the helps for that in current medicine is, no FDA approved medications for that, but, we're all aware that they have vitamin cocktails that they're recommending along with diet, avoiding stress, which would be helpful, avoiding extremes in temperatures, and then just medications to treat the symptoms that come along. But the exciting part is at the bottom with physical therapy, occupational therapy, and speech, language pathology, that I focus on the range of motion and improving energy management and energy conservation and function. Some of the things that the physical therapists often treat are the problems of muscle weakness and atrophy and the developmental delay, and that reaching the milestones as far as rolling, sitting, walking on time. Some of the lethargy and exercise intolerance is one of the things that is a huge hindrance to activity and having fun in life, and so we work on that. In the low muscle tone, one of the huge things that it causes is the scoliosis and the curve in the spine. So we're working on increasing the muscle tone. With the ataxia, it's missing the point with a hand or a foot, typically, total body, is when you reach out for something and you're missing what you're aiming at. We work on that coordination. And altered control over breathing, that when the muscles weaken, then you have less breath support, and with less breath support, then you really, folks don't want to do much activity then. And then some of the issues with the stroke symptoms that physical therapy is instrumental in working on the strength and balance for that. Let's look exactly what PTs do when I do an evaluation. That I start out looking at function and asking someone to move and kind of watch them and observe them move, and look at the rolling, the sitting up, the coming up to stand if possible, and the walking, and doing a gait evaluation to see exactly what deviations are present. Often you'll see the standardized assessments for children. The P-body is on the bottom, and it looks at all the different milestones, as well as the Bailey, if you've had those performed. They take about 45 minutes to an hour, and the helpful part of it is it gives you an actual age that you're performing at. So as typically the child is moving and doing all of these different tasks, then it kind of slots out to Okay, the child may be 9 months natural age, but they may be performing at a 6-month age. So it kind of gives a little guideline as to how far the developmental delay is. And those tests aren't done very often, usually every 6 months or a year, just as a guideline. And so we do a nice treatment plan based on the goals that the child wants and the parent wants, and the therapist will help set those goals. This is a cool graph. The whole field of physical therapy is based on the ICF model, that International Classification of Function. And what we do is we start at participation and say, what do you want to be able to do? I want to play soccer. Okay, what do you have to be able to do to play soccer? Well, you've got to kick the ball. If you can't walk, you've got to be able to roll, or you've got to have somebody to help roll. And you have to have head control and all of those different items involved in playing. And we back it up to body and function and say, what muscles are weak? What's causing your balance to be off? And work very specifically on those things, with the end game being getting to participate in that sport or whatever life activity you want to do. One example on the Friedreich's ataxia, with all of the balance issues and coordination issues, that when there is a loss of coordination, that we specifically work on coordination exercises. If it's quite severe and progressing, then we work on what other ways can we get that same activities performed. So we're conscious about the energy conservation, and with vision and hearing, we work with it and around it and often refer out to specialists just for that. We love working on scoliosis and preventing scoliosis for the big part by doing tons of positioning in prone, which is belly line, supine, which is back line, in sitting with all the braces and extra supports, and some of the extra braces that the folks can wear. For diabetes and heart, we kind of monitor those to make sure blood sugar levels are okay, and monitor the heart rate and blood pressure for the heart arrhythmias that happen. And then I put respect under unaffected mental abilities, because we're very particular that the person, the patient, is driving the therapy, and what all they want to do is what we want to do, and very much on respect for that. So there are other medical considerations that we keep in the back of our mind at all times when treating. Highlighting this one because in this particular myopathy, that there's often a lot of migraines, a lot of stroke symptoms, where the one side, maybe the right arm or leg, gets really weak, and that affects everything. And so you may have heard of some of the techniques, the sensory integration or neurodevelopmental treatment techniques. Those are handling techniques that therapists use that I've been trained in, that you can actually input with your hands what the person needs. Where it's weak, you can put them in a normal posture and get them to feel what normal feels like and retrain the muscles. Here's a picture of some of the braces. The Milwaukee brace is the traditional one. It has been upgraded. You know, it used to be the old leather straps. And then the Boston brace is a little more comfortable. And if the cervical area is not involved, then often just the TLSO, the thoracic, lumbar, sacral orthosis would be here. So PT would recommend which brace, the orthotist would make it, and as we're doing exercises, we would train the individual to work with the brace and take the brace off and train the muscles. Scoliosis usually happens when one side is a little weaker and it pulls, or with the strokes that one side may be actually pulling with the spasticity. And one of the things, you may have seen these, it's the Velcro and fabric, that it's like a wetsuit, a snug suit, and it helps the person to, sensory-wise, just be able to pull themselves together and get better information proprioceptively, and to be able to gain that input from fabric. And what it kind of does is, if you've worn some of the athletic fabric, it kind of tucks you in and gives you a little bit extra posture. They're actually made, you can put extra supports on the back and so forth, and Velcro in. So it is a little bit of hassle putting on, but the way that they're open and you can Velcro in, you don't have to pull it on and skimmy it on like a girdle. So that's a perk. And they have supports in the back to pull your shoulders back and your scapulas back, and reduce some of the problems that could come, and they're pretty comfortable compared to those braces. Occupational therapy is fabulous about positioning, but physical therapy also has a respect for it. We often work together as a team to build some of these items. That you need to be able to have a good posture to lay in on your side, on your tummy, in all fours if possible, in sitting up, and to be supported. There's a little tweak on positioning items that if you position perfectly and tight to where you can't move, you look good, but you can't move. And so it kind of defeats the old function purpose. And so just enough support in the right places will hold you up, and then you can do what you want to do. So that's one of the cool parts. For developmental delay, that's what physical therapy focuses on just a whole lot. Trying to get those milestones built up to where you can hit the maximum functional level, be able to roll over on your own, sit up on your own, and get up on your own is just huge. Test your memory. All of y'all were 1 month old at some point, so think back and see if you remember this. But being able to lay on your tummy and pick your head up for a moment and then come back down. And just forearms just kind of underneath you. It was a kind of a low budget month. And so at month 2, pick your head up a little bit higher, elevate up to 45 to look around a little bit, and arms kind of holding you up a smidge. But by the time you get to 4 months, you can be on your tummy, look up and around all you want, and be able to roll over side to side. And by 6 months, it's a big hallmark, independent sitting. Not really playing and picking up stuff you might fall over, but being able to sit there on your own. So that's a huge number that a lot of folks will go by, and it's a kind of an indicator. So if a child is not actually sitting up independent by 24 months old, it's a big red flag for prognosis and future helps for us. And so we've got 8 to 9 months, be able to crawl around. In therapist language, creeping is what Mama always called crawling. All 4 getting at it. And then crawling is on your belly and army crawling. I just reported, I tell my students that I didn't make it up to confuse them, but that's what the books say. And at 10 to 15 months walking, at 2 be running, at 3 ride a tricycle, at 4 be able to get up on your tippy toes, and at 5 be able to skip and dress yourself. And so this is the standard that we're trying to hit for everyone, and even if the milestones are hit later, it is a goal that most everyone wants to hit. Okay. So we work on the breathing muscles too, work on the tone. This is a lot of fun. Actually putting the child in these developmental postures and getting them used to it and being able to function in those is absolutely huge. And for those with ataxia, actually working on the gait, working on the coordination. If you need leg braces, getting the leg braces, getting them to fit right, using the absolute minimum bracing to be able to do what we need to do is what we're into. And that's my PT. Thank you. Thank you very much. Do you need this?
Sure.
Sorry about that. I think I'm moving the mic around. This is Dr. Missy Bryan, and she has 19 years of experience of pediatric occupational therapy. She is working in an outpatient home health setting. She is a RES, you're gonna tell us these
Yeah.
later, right?
Sure, yes.
RES and a certified assistive technology professional and a child passenger safety technician. She currently teaches in the occupational therapy programs at Belmont University in Nashville. She also serves children and families in the seating and mobility clinic and the specialized transportation clinics at Monroe Carroll Jr. Children's Hospital in Vanderbilt. With that, I turn you to the mic.
Thank you. Hi, good morning, everyone. Thanks for having us. So I am an occupational therapist, just like she said. My primary clinical work is through the Children's Hospital at Vanderbilt. And my focus right now is primarily on assistive technology. So I'm going to talk to you a little bit about occupational therapy in general, and then I'm going to talk about some adaptive equipment in general, just in case you are in need of any of that. So just a poll, how many of you have had some experience with occupational therapy, or the person that you love who has mine has? Okay, so lots of people. Okay, so that's good. In general, you're going to have an understanding of what we do. So I just want to say I do have some products on my slides. I don't have any financial interest with any of them, nor is inclusion of any of the products an endorsement for that product. I just want to show you kind of the spectrum of what types of equipment are available to help you in decision making. Also, on the slides, I just have pictures, but at the end I do have links that go to each of the products, so that if you do want to look more in depth at a product, you could locate it that way. So what is occupational therapy? What really our passion is focus on meaningful life participation. So as an occupational therapist, it is my desire to help my clients be able to engage in the things that matter to them. So that might be, I love swimming, and so I want to find a way to do that. That might be, what, I really want to be independent with taking care of myself, and how do we do that? And so we do that through the use of everyday life activities in a therapeutic manner. And you will find occupational therapists providing service really in any setting. So we might be in homes and schools and clinics and hospitals in the community. And so we look at occupations, and those are just the things that we do during our day. So that might be self-care. Can I get dressed, get in the shower, get to, drive to work? How's my rest and sleep going? We look at education and work. We don't just find people jobs. That's what people think occupational therapy is. That's not what we do. Also the ability to play and do the things that you want for leisure and be able to socially interact in a way that is meaningful. And if you're having trouble with any of those, then that's where we really work on an individual basis to come up with strategies to address that. And so the approaches that an occupational therapist takes, we address symptoms really. We address issues with function and participation. We're not, we are not necessarily making your mitochondrial disorder change or better, but we are hopefully helping you learn to function and live with and through that. And so different strategies we might use a remediation strategy. So if you do have muscle weakness or difficulty moving about, we might come up with some ways to help strengthen or improve your function. A lot of what we do is modification. So we might modify the way you approach a task or an activity to help you be able to function. We might actually make modifications to an item, so using some type of adaptive equipment to help facilitate that participation. And then the other thing that we do is address prevention. So in the case of, developing scoliosis or something like that, we might look at positioning to help prevent progression of that. So now I'm going to kind of shift from just traditional occupational therapy and talk about adaptive equipment. And so we will cover each of these on the next few slides. And because we have just an hour and there's 3 disciplines, then this is really a highlights reel. We're just the bare bones. But one area of assistive technology that we look at is adaptive seating. And so a lot of people might need some additional support to be able to sit or to sit for a significant length of time. And you might do something as basic as if it's now I work with children and I recognize that we're presenting for children and adults. All of my language will probably be geared toward children just because that's what I'm used to, but you can find products for adults as well. So if I'm leaning toward the pediatric side, I'm sorry for that. But so you might be able to find something as simple as a booster seat that you can buy at Walmart or Target to provide enough positioning and support for a child. But if the child needs more postural support than that, or needs maybe some additional features, there are certainly products that can provide significant support. So if you see over here on the right, the chair in the pink in the middle, that is kind of one of the higher end positioning chairs, and it can raise and lower so that you could be down low to the ground to play with siblings or peers and raise up to a table height, be at various heights for different tables. And then it also has adjustable positioning supports as well. It can sit upright, it can tilt back, it can even tilt a little bit forward to help you be able to stand up to transfer out. And so just know that there are many, many options out there. We also, as occupational therapists, look at adaptive equipment for your self-care, your activity days, or your activities of daily living. And so that might be as simple as purchasing the middle picture is non-skid shelf liner. So if you're having difficulty with, as you're trying to scoop, the food out of your bowl with a spoon and you have difficulty with coordination and your bowl sliding around, maybe we can just get some, $3 shelf liner, put it under the bowl and help prevent that sliding. We might adapt handles on toothbrushes and feeding utensils and whatever else you need to grasp if you're having difficulty grasping the traditional item. Using an electric toothbrush might be helpful because it reduces the amount of coordination that you have to use to be able to brush your teeth. And so there are literally millions of different adaptations for activities of daily living, but that is something that working with a therapist could help with. Bathing and toileting products. The simplest items I would say are like the one on your left is for kids who maybe just need a little bit of extra support sitting. They can still be in the bathtub. They are able to bathe, but they need just some trunk support. And then there are other supports that would be maybe for larger children or for adults that would assist with transferring and positioning for bathing. So the middle picture is that. It's a higher type device where you can transfer and then it slides over into the bathtub. And then the one over on the right is a bath lift. And so that would be useful for someone who needs to, maybe the transfer is difficult, so it raises up to the height of the side of the tub. You can transfer on and then use a remote control to descend down into the tub and be able to take your bath. Car seats. So we have at Vanderbilt a special needs transportation clinic. Primarily we are serving children and young adults who have basically outgrown commercial car seats, but they still need the postural support of a car seat. And then also some kids who come to us they don't have the maturity or the safety awareness to be able to stay in their seats, so there are some seats that have some anti-escape safety features as well. But I think this is probably an area, if I think there's an underrepresented area, I think safety during transportation is one of them. But just know that there are people out there who can help you with that and help make sure that you are being able to be safe while you're riding in the car and well supported. Walkers and standers. Generally, this is going to be managed by physical therapy. So you're not usually going to see an occupational therapist for a walker or a stander. But I wanted to include it just as we're talking through assistive technology devices. This might range from as simple as a simple walker or a cane to a gait trainer or a standing device. And there are benefits to standing, so even if you're not able to walk, there are certainly benefits to standing in that it can help increase or maintain your bone density. There are huge benefits to just digestion. Getting in that standing position can really help with digestion and avoidance of constipation and that type of thing. So if you're looking for a walker or stander, I would say call your PT. Wheelchairs are another common item for individuals who have a mobility impairment. Someone who just has difficulty walking long distances might be able to use a device as simple as a stroller where, I get fatigued during the day. If it's a child, maybe they can walk around in their classroom just fine, but to go from here to the playground or here to the cafeteria is really challenging. And so a stroller could really help with that energy conservation throughout the day. Manual wheelchairs are also an option for individuals who have the strength and endurance to be able to self-propel throughout the day using their arms. And then power wheelchairs are also certainly an option. You can get basic wheelchairs and you can get customized wheelchairs as well. I would say if you are going to be seated in the device for a significant period of time during the day, I would look into custom options just to make sure that you are comfortable and well supported throughout the day. All right, and so then this is really what I consider to be the most important portion of this is how do you go about selecting adaptive equipment if you need it? So I know you guys are probably from all over the country, potentially the world. So you want to look around in your area and find someone who is knowledgeable about assistive technology products, about adaptive equipment. And so if you are looking for a wheelchair, find someone who knows not just about basic wheelchairs, but knows a lot about wheelchairs. Hopefully you can find a therapist and a supplier who have good knowledge, good broad knowledge of the products that are available. You all probably recognize it is unlikely that you're going to find someone who knows a ton about Mito, right? Who's a clinician who knows a ton about that. And so I always point out to families that we really are working in a team. So I, as a therapist, bring knowledge about child development, about mobility, about how bodies are affected over time by disability. The assistive technology supplier knows about products. They know about items. I might say, you know what, we need a product that can grow over time and does this, this, and this. And they can say, oh, well, you know what, this product does that and that and that. But you are the expert on your situation, on the course of whatever the condition is, on what your home is like, on what your life is like, on, maybe you need an item that can be used at home and school and playground and in the community. And so those really aspects all need to be addressed together in a team to come up with the best outcome. How many of you guys have gotten some type of equipment that you thought was going to be great and then you got it home and it didn't quite meet exactly what you wanted it to do? Pretty good number, right? And so we can't eliminate that. We're never going to always make a perfect decision, but hopefully if we're all contributing our knowledge as a team, we can come up with the best solution that works most of the time. So something else to consider is we want to make sure that whatever you're choosing meets your needs right now, but it also needs to meet your needs in the future. And so for children, growth is something we consider. You're likely going to get bigger over time. It needs to fit you now, but it probably also needs to fit you in 3 or 4 years, especially if you're getting the item through insurance, because they're not going to smile when you ask them to pay for it every year. And so you want to do your due diligence on making sure that it can grow. But also, if your condition is changing, we want to make sure that whatever we get is customizable to be able to meet your needs as that changes in the future. A lot of times we think about high-tech options, but recognize that low-tech options can be great solutions as well. So you could get, a really high-priced medical device, but it's possible that you could have found a commercially available device that could potentially integrate better into your life and meet your needs even more. So don't throw out that idea of choosing something that's commercially available. And then the other thing is to make sure that before you agree to obtain an item, that you get your hands on it and see it and try it. So I showed you pictures of car seats. How many of you have ever seen a medical car seat? Not that many. I can say to a family, these car seats are big. I can promise you, every time I bring one out of the closet and I say, this is the big car seat, they go, oh, like it's big, it's really big, and putting it in my car takes a lot of space. And so you want to know what you're getting if you're choosing a piece of equipment. And so high quality suppliers should agree to get a demo item for you. And so even if you're at an evaluation, you're working with a therapist, you're working with a supplier, they show it to you in a magazine, I show you a website, I show you a video, and I say, look what it can do. If you aren't confident that that's a great choice, say, can you get one so that I can see it and touch it and put my child in it and be able to interact with it so that you know, or at least have a good idea of whether it's going to meet your needs or not. And then also, as you are thinking about items, everything looks shiny in a showroom. Think about, like, how is it really going to integrate into your life? How are we going to use it? When are we going to use it? Where are we going to use it? And that will help you in making decisions. I think that's it for me. Here are links. So we'll pass it off to Melanie, who is a speech therapist. There's a little timer up there if you want it.
So I do not have any slides, and I'm really going to just talk for like 2 minutes so we have lots of time for questions. So I'm a speech language pathologist, and I have experience in clinical situations and in school situations. And in general, how many of you have interacted with a speech language pathologist or audiologist? Okay, so most of you know what we do. And so the broader focus is on communication and hearing, and not specifically on talking per se, but realizing that everybody needs to communicate however that needs to happen for various people. So that really is all I want to say about what I do, because I want to leave the rest of the time for questions and discussions, because I know that's a key piece. So do you guys just want to come up and stand here, and we'll field questions and thoughts and what you need help thinking about? Let's start over here.
Hi, I have a PT question.
Okay.
The posture and torso alignment system, is that specifically for scoliosis? And I'll tell you why. A physiatrist that we work with had recommended a DMO suit for my son, a dynamic movement orthosis, and it was an unmitigated disaster for a variety of reasons. And I'm wondering if the alignment system might serve the same or similar purpose, but maybe work a little bit better for us.
That's also one of those items that you really need to try it before you buy it.
Yeah.
So ideally the therapist would Velcro on, or put the lines where they think they need to be with the Velcro system before you go to order it. One of the big challenges of that, I think, is the cost. That just for a nice Velcro suit can be easily $1,000. And for a growing child, it's a.
Are they the same thing though? Is the posture and torso alignment system the same thing as the EMO suit?
Well, it could be.
Okay.
One of the different. It's like some of it is related to the actual brand names versus what one does versus another.
Okay.
The very minimalistic type is the type that you put on like a scuba suit and Velcro in. Is that what you had?
Yeah.
Okay.
And one of the reasons it was an issue was not because of the suit itself, but it apparently came from London, and it got caught up in customs, and then by the time we actually got it, he had grown, because it was like 8 months later, and it
Oh,
didn't
my.
fit him, and he screamed when we tried to put it on. It was just
That-
it was not fun.
That sounds like a no for like several reasons.
Yeah.
It may be one that you want to revisit and go a little more closer to home.
Right.
But I would try it again. Yes, the systems are the same for some things, but in some of the sewed-on systems where you can actually zip in and Velcro in, they're much easier to put on, and then you get the straps sewn into it to hold you a little better. So it may actually work. And for scoliosis, yes, it does have some impacts to scoliosis, but it's the least anti-scoliosis product because it's not a hard and fast.
But it's not necessarily, like, he doesn't have scoliosis.
Right.
This was recommended for muscle compression.
Right. The number one reason I put those on folks is for hypotonia.
Okay.
Yeah.
And then the other thing that I would add, which is really just supplementing what you guys were saying, we have several equipment closets where I live, and I'm sure everyone does as well. You know, you get that equipment and your kids outgrow it, or it doesn't end up being the right fit. And I have several times borrowed equipment from the equipment closet to try it before we buy it, kind of a thing.
That is totally an awesome idea. Very much so. Even if you could just borrow it and use it from the equipment closet, but if you wanted your own, yes, just to be like Missy was saying, just to be able to get in the equipment and live in it in a few minutes or a few days and go, yeah.
And we have, I mean, we've ended up making the decision not to get something based on our experience after borrowing it from the equipment closet, and then we've also gone like full bore and like, yes, we need to get this immediately. It needs to be ours.
And I think you're very smart for doing it that way. What we see as therapists is some families are, I want the latest new equipment, period, and they have like closets at home full of things.
Yeah.
And then we see the other end of the spectrum where people don't want any equipment. It's really hard to make stuff happen. But yeah, you did good.
Next.
Okay, I have a question for sort of all of you guys. So, like, I know I'm physical therapy. I've been physical therapy my whole life. I'm also speech therapy right now, but she came back to lose me. And so, like, what do you recommend? Like, do you recommend that you do therapy throughout your whole lifespan and have a chronic disorder, or do you recommend that like you stop and start again when you need it?
So I'll start. I think in general, I think of it as every year. Every year of our life or every school year brings new and different challenges. And so you have to think about what help you need at that point in time to accomplish what you want to accomplish for yourself. So your ICF thing is a really good place to think about it. And so sometimes the challenges aren't there, and then sometimes there are challenges. And so being open to what is it that I need to do and accomplish in my life, and how can the therapist help me accomplish that, and realizing that it's not a situation of, okay, I'm done with that, but rather what are my challenges and what do I need to meet those challenges.
And then from a physical therapy standpoint, hopefully that when you finish your round of therapy, that you'll be able to follow up. And that's why we have all the home programs and exercise areas, and that's how Planet Fitness makes their money. that you can move into the more mainstream exercises, the actual yoga classes, you know, the core Pilates classes. Those are just amazing to keep up the strength. And if you can keep your core strength and do some exercise programs on your own, then until you hit a bump in the road, you don't need to go back to therapy. That the goal of the therapist is to make you not need us.
Maybe, maybe not. So yes, I am in agreement with that. Certainly when kids are young, or when you have a newly diagnosed condition and you're trying to get it figured out, we do tend to do more kind of constant therapy, you know, that is longer term. But as you get more familiar with your situation, with your condition. We move to what we call an episodes of care model. And basically it is when you come into us for an evaluation, you say, these are my concerns, these are the challenges I'm having right now. We come up with a treatment plan that addresses those challenges, and assuming that nothing new has come up, then once we kind of get a plan figured out for how to work on that, then we might take a break from therapy until something new arises. Maybe you're going to a different school the next year. You're going to have to be able to walk much longer distances or something like that. Or you've reached a time in your life where you're wanting to take on a new level of independence. Then that's when we would say, okay, then come back and see us and let's come up with a plan then. So I really kind of see therapists almost as like problem solve, like help with problem solving.
Back here.
Thank you. My next question is directed to speech. I have a daughter diagnosed with Lee's disease, and with that, she had perfect speech when she was first assessed with CPST about 16 months ago. She was almost a year in advance. That's how far speech, top of the spectrum. Speech has declined, and she had a virus in December, and it just kind of plummeted, and to where we couldn't quite understand her. We got speech involved. First speech therapist was not familiar with Mito. It was just, in there with an iPad app, and it wasn't going well. I researched. I got someone who was familiar with neuro and speech, because really that's what you need. You need that combination, because the whole way family and the mind is affected with Lee's. And so I researched until I found a neuro speech person. And the neuro speech person did a program called Loud. It was intensive. It was 45 minutes every day for several weeks, 5 days, 4 days a week, and homework on top of that. However, her speech came back. And it is loud. It is something that I realized that when we didn't do it, we came back off of the everyday for 45 minutes, and it went to 1 day a week. And I saw, okay, it's progressing. You've got to get back on this and hammer it up a little bit. Now, this wonderful lady who has been a help for the past 6 months has now left my area. So the first question is, what recommendations, plans can you advise us to do with specifically Mito patients that have neurological issues? And then secondly, what recommendations do you have for finding a experienced Mito and neuro speech therapist to work with my child? And I'm in the Charlotte, North Carolina area. So if you have a database or something that you can just tell me the website.
So I think that Loud is associated with LSVT. Do you know that? For LSVT is a similar kind of program for patients that have Parkinson's.
It is. That's exactly
Right.
the program we did.
Okay, and so they're certified in that. So they go to training and they get a certification from that organization. And so that organization should have a body of people who have those skills. The other option is to try the ASHA database, the American Speech Language Hearing Association. And ASHA, if you just go to asha.org, ASHA.org, there'll be a toll-free hotline, and you can call, and in like our registration with our professional organization, we can list particular certifications. And so they should be able to direct you to somebody. The other option I would say, so you're in North Carolina, call the University of North Carolina at Chapel Hill, and talk to Katrina, no, that's not her name. I'll look it up. So like your major universities, somebody should know who the heck. Your minor universities aren't necessarily so connected with people. Definitely in terms of speech language pathologists, we kind of break into adult versus pediatric, and the adult folks have much more experience with neurological diseases because those are more prevalent in the adult population. The pediatric SLPs are much more focused from a developmental perspective, and so Mito presents a really different kind of challenge because it's more like the adult neurological diseases than the pediatric diseases. And so I would encourage you to not necessarily think about peds versus adults, but think about who has that neurological experience.
That's what I did, exactly.
Yeah.
The one that had did both, and she was, like I said, she's fabulous, but she's moving out of state.
Yeah. And she doesn't know anybody else. Did she have
I
any
don't know who her replacement's going to be.
Okay.
She was kind of outpatient from
Yeah.
the hospital, but anybody in Mississippi who needs her, I can share the name of who.
All right, so let me look up this person's name from North Carolina.
Yeah, I have two quick questions. The first one was the Vanderbilt clinic for all ages or just for children?
So I work in the pediatric clinic, so we have a pediatric. Okay, go ahead.
The second question is for all three. For those of us that deal with minor both as an adult and with our kids, what advice do you have for us as far as how long we should let a green therapist work with us that has no clue with minor, or should we just start from the get-go? Because we get tired of training.
About 15 minutes.
There we go. Well, I would give a little bit longer than that. I would see how quickly they study and get up to speed on your condition. So yes, I work in the pediatric clinic, but there's an adult seating and mobility clinic, and then the adult neuro program is Pi Beta Phi. And so if you were looking for more kind of general adult neuro kind of things, I think that's where you could go. So yes, I do think that the chance of you coming across a green therapist who says, Mito, what, is high, very high. But I think that what I would want, if you were coming in and you were my patient and you say, listen, we have Mito, and I'm like, okay, well, that's great. I don't know much about that. I would want you to give me a little bit of history on, like, okay, so here's a little bit about our condition, how it affects, my child, myself, my family. Here's somewhat of what our progression has been like over time. Here's, some resources. So you might, even just tell them about the UMDF website, and hopefully that will inspire them to do some research and to do some learning. And so I think that would take a little bit of time, but I don't know that you don't give a 2-year trial either. Does that make sense?
True, I agree with you on that. I will say that as a PT, the skills I have for any particular patient in assessment is the same, but I can pick out exactly what the gait deviations are and what is weak and what is imbalanced. So for all of those things, I can handle all of that for any diagnosis because it's the hands-on and the critical thinking. But when you get into the particular diagnosis and prognosis and things, if they're interested enough to look it up in the next visit that you come, that they have this new wealth of knowledge, then it's worth hanging with. But if they still seem to just trying to fit you into schedule and stuff, then that's probably my last visit.
And I would just also advocate for really open communication between you and the therapist. So if the therapist is not meeting your needs, I would say be open with them and say, you know what, really when I came into this, here was my expectation of what I thought I might get out of it, and I'm not quite getting that out of it. Can we come up with a way to figure out how to maximize my benefit from it? So I think just be really open, and not necessarily like aggressive, but just open with, can we come to a solution to this, to solve this problem together, and then I think that might help you find a match that works for you.
Yes, sir.
So you might not know the answer to this question, but for 2 different insurance companies, it's been told to us that there's 30 sessions allowed per year. Do you know how they got to that number? Because there's 52 weeks in a year, why not?
And sometimes the 30 visits per year is generous. Some of the plans have it down to 20. And some of the plans that don't have a cap, what they do is, it looks like they don't have a cap, but when you go to sign up for therapy, then they manage the visits. So micromanage is actually trying to squeak out less. And there's not a highly intelligent reason why they limit it other than when they do the huge studies of where their money goes, they're cutting therapies off. I know that's bad, but
I can actually answer a little bit of that, because I used to work in insurance industry. When your employer goes and gets the underwriting done for the group policies for their employees, they have to choose whether they're gonna have POP or speech writers unless you're taking a exit, or if you're on a federal plan policy or mandated by ERISA. And so if your employer wants to cut costs on it and stuff, they might choose the bottom of the low liability type car insurance plan for your healthcare insurance instead of the grand full premium, full coverage policy that includes everything with unlimited PPST benefits.
yeah.
So if you're unhappy with your insurance and you're with a group employer, talk to your HR
That's
to get
very
better.
true. Yes, sir.
I have a question that's sort of related to that. So there's some school of thought that says that intensive therapy sessions can be more effective in providing long-lasting benefit. And so, if your insurance company only allows 20 sessions, can you work with them and say, okay, well, let's do an intensive and do 10 sessions in 1 week through a particular provider? Is that something that you recommend or have experience doing? That's the first question, and I have a follow-on to that.
I like intensive therapy if I'm doing particular things. So for me, I'll let Missy answer too. It depends on what I'm working on. If it's constraint induced, if you have like a stroke on one side of your body and one side doesn't work very well and you're not using it a whole lot, then we can wrap up the strong side and it makes you use this one. So intensive and more time really works for that. But if you had, for example, low back pain, it wouldn't work for that.
Right.
So it's kind of,
And I agree. I think it's based on what is the issue that you're addressing and what is the therapy that you're providing. I also think sometimes it's a challenge because you are getting therapy at a therapy location and they have a certain way that they usually structure that, right? So they're once a weekers or they're 3 times a weekers. And so it might be a challenge to try to get a therapy that does fit a different model. And once again, I would say the best way to deal with that is just open communication and say, I know you recommended this, however, I'm wondering if an intensive might be more appropriate. What do you think about that? And ask your therapist.
And then related to the different model thing you just mentioned, what's your experience or opinion on alternate modalities like a not-been-yell method or Moscatova or Quevis-Medic? Do you guys have experience or opinions on those?
I don't have direct personal experience. Now I have some families who have used both the Anot-Banyel and Moscatova who are strong advocates for that, but I don't have a lot of personal experience with it.
What are those? I have no idea what they are.
So those are all
Physical.
they're alternate modalities that are more focused on movement and just focusing on really small movements that sort of expand. And it's basically retraining the brain to be just train the brain to move in different ways. And it's not just sort of repetitive, big PT/OT kind of things, but just a more subtle approach. And generally, they're not covered by insurance, and they're pretty expensive. But we've tried some of them, and we've talked to other families who have had same experience. They really swear by them.
I have seen some folks that do really swear by it. So it's one of those that if it's going to work, you're going to know it pretty quick.
Yeah.
And if your body responds to it, then it makes you want more.
Yep.
But a couple sessions in, you're not seeing anything, move on. Now, I'm neurodevelopmental treatment trained, and so with the handling that I have, putting folks through the normal motions, it's on the same order, and I've seen it do some fabulous things. So depending on your location and your energy and your budget, I would pick the one that I could mimic at home the easiest, because the goal is not to be stuck dependent on somebody, it's to be able to do your own stuff.
And I think anytime you're trying some type of alternative therapy that you're not sure it's going to work, you're trying to figure out, and I would say, with any treatment that you're doing, I think just going about it in a smart way is good. So try as much as you can to kind of isolate that so that it's the new different thing in your life. So that then you can see, like, okay, so we're putting lots of time and energy into this, and is it having a good payout or not? Are we getting benefit from it? As opposed to trying 5 new things all at once, and then you think, some things are a little bit better, but you can't tease out kind of what it is that was better. But I'm all for trying, trying new things, but
And I'll second
try to
that.
measure that as much as you
That
can.
one of the things too is when you're getting OT and PT together, to make sure that the OT and the PT are doing the same theory. And so if you do get into an alternative thing, we're totally fine with that, but we need to know. Some of the times I've been frustrated is when I'm plowing ahead and then find out they're doing something different at night, totally different, and I think it confuses the neurological system. So, yeah, pick one and run. I think she's given us the wave off, and we'd really like to answer your questions, so if we can,
2 more?
can we get
Oh.
those?
She can ask your questions, but I will ask that anyone who wants to slide out, I need to make sure you have your eval and that you hand that to me. But if you guys have a few extra minutes, feel free to.
Thank you.
You want to go?
Yeah, the lady in the back actually brought up the questions about speech therapy, and I just want a general opinion. Do physical and occupational therapy generally address the effect, not the cause? And does that differ in speech therapy? Because it seems that the causes of speech therapy, it's really important to address the cause, because those causes often change, as they do, I'm sure, with physical and occupational. But
So I would say that varies by clinicians and what your training is. So I'll give you an example from when I work with kids. So I work with kids that have the whole range of cognitive abilities. And I find it really, not that an IQ test tells me exactly how a child is, but it's a piece of the puzzle. And so I'm going to expect different rates of change, for example, depending on what your IQ is, and I need to know that piece of the puzzle. There are some of my other colleagues that could care less. So really, I mean, and what these two have said, you have to think about and ask the folks that you're working with, like, where are you coming from when you're thinking about this? Yeah.
Most, you all said it, that therapists that don't know what mitochondrial disease is.
Right.
So how do you address the cause if you don't even understand the cause?
Right. So I will tell you, I know nothing about mitochondrial disease. So when Tyler Rhyme Chisel asked me to be here to do this, I went and read, and then I emailed my entire staff and said, okay, who can tell me something about this? And it so happens to be that there's someone on our staff that has mitochondrial disease. Maybe. You know what, since we're going to go ahead and answer some questions, if you're having a conversation, if you guys want to go out in the hall, that'll be easier for the people that are here. Okay, so, I emailed my group, and somebody came back and gave me a fantastic set of information. Now, so one of the questions isn't so much on day one, what do you know about my disease, especially when it's a rare disease? Because across the country, there's going to be a limited number of people that actually have experience with multiple people with a rare disease. So it's really about finding that person that's intellectually curious about your disease, whatever it happens to be. And if you feel like you're working with somebody who's not intellectually curious alongside being compassionate, then you probably need to go find somebody else. And I know that that's really frustrating, but that's true in every...
So would you go back to the resources that you spoke about earlier as places to start to maybe find some expertise?
Yeah.
And I'll tell you a little bit about, you were talking about the PT's work on the cause or the effect, and there's 2 theories running. One is rehabilitative, where we dig down to the bottom, find the actual muscle, the actual motion, and fix that. range of motion and strength and balance, and then the problem gets better. That's more on the rehab side. There's another side on the compensatory side where we just take you as you are and try to add some braces here or there and not really working on the actual problem, but that's kind of that's a bit of a throw in the towel theory on one hand, but on the other hand, if you're only working on this, but you never give someone an extra help so they can function where they're at, so there's a little balance there. In folks that have the stroke, we have a big discussion. Do you just give them the cane right away or not and actually work on midline? And so I know exactly what you're talking about.
My daughter has PT, OT, and speech, language, and learning. I understand the value in PT and OT, collaborating, coordinating, but I'm curious about the importance of speech, language, and learning collaborating and coordinating with PT and OT. Do you see that as a requirement or important or not so needed?
So I would say it's essential, particularly when you're talking about things that have like neurological components. So I have some kids that I work with that I'm working on speech and language and somebody's working on handwriting, so the overlap is there a little bit but not huge. So thinking about like what your particular goals are, and definitely thinking about like seating and posturing can make a big difference in somebody's attention and all of those kinds of things. So if those pieces are really important, how old's your child?
8.
Yeah, so if those pieces are really important, that is essential. Now, you'll find some PTs, OTs in speech that treat. That's easier in some places than others because of insurance and those kinds of things. I assume your child goes to school, and so those folks are not bound by having to write notes and getting paid for like that note. So school's a great opportunity for PT, OT, and speech to collaborate. And sometimes you'll get pushback because, well, PT, OT, and speech aren't there at the same day. And your response to that always should be, that sounds like a problem that you all need to work out.
Thankfully, we're in the Kaiser system, and so
Yeah.
it's an integrated health system.
Oh, yeah.
Plan, so it
Yeah.
should be pretty easy to get
Yeah.
them together.
And I will
Thank you.
speak to, I think there's benefit in that collaboration, really, with anything that you're doing. It would be better if all of our care team was all in one room and had one meeting and everybody came out with a plan and we do that plan and everybody's really consistent with it. It's not the way our world works very well right now, but it would be great. But as an occupational therapist, I care very much what's happening in speech therapy, because even though I'm not doing therapy as an OT specifically to improve your child's communication's embedded in everything I do. I want to have a good understanding of what that child understands about the instructions I'm giving them. I also want to understand any communication they're giving me, so I do think there's certainly benefit to that.
And I'll throw in a little bit on positioning. If I'm working on making sure they're comfortable in their chair and up tall enough, if they're sitting like this, then the speech is so effective that sometimes it's a simple low budget answer. Fix their posture, then all of a sudden they have stronger speech abilities and swallowing. So that's a big perk.
Just like as a little example, I go in sometimes to the schools and the little preschoolers are sitting at tables that are designed for big kids. And so in a half hour, all I see is the kid continuing to like fall off the chair. And I'm thinking, like, how much energy is left for learning and speech and language when you're spending your whole time, falling off the chair? Like, that's just ridiculous. And it's when I say something, the answer is, well, that's the table they gave me. And my response is, well, that's the table you need to get rid of. So I think sometimes people just don't think logically about some things. And so really pushing people to think logically and do that collaboration, because it's so important.
I know you had a question.
So my daughter has done the same PT since she was 18 months old. She'll be 5 in 4 months. So we love her. She's always been great to her. Within the last 6 months, she has been very angry. She's not wanting to do PT, screaming, like head banging, terrible. And our PT, we adore her, she adores Riley, and she's like, I don't know what to do, what should we do? Sometimes she'll do good, she lets Riley lead the therapist, but she's like, I just want to keep her moving, we don't want her to regress. But she wanted me to ask you guys if you have any tips on what she should do. We started taking like a little break, and like a 15-minute break in between, and we also started ABA therapy. Because she does great in OT and speech, but it's like doctor's appointments now, she's starting to throw tantrums, I don't know if she's becoming her own, she's nonverbal. So frustration.
How old?
She'll be 5 in November
And where do you do the therapy?
at Jones Therapy.
Okay, so it's at a clinic, right?
Yeah, it's in
Okay,
Pittsburgh.
okay. That's what I was wondering, like, could you change, so since she is tolerating some therapies and not that, could you change something about it? Change location, do it in a different room, do it at a different time, like, brainstorm with your therapist and think, what can we change? And
She was like,
figure
"Go
out.
ahead and ask them, what
Mhm.
can we do?"
Yeah, right. What's something totally different?
A baby.
Yeah. And sometimes I will, especially if it's a child that I have a history with and I've worked with for a long time, and we just have gotten into a place that's not going well, I might just change like what I do. Like I might do a therapy session that doesn't look anything like any other session I've done. It might not even look, like OT, or for a PT, it might not look like PT, just to try to see, can we get a little reset here? The other thing that I have done is I have taken a break for like a specified amount of time of, okay, this is clearly not going well, it's not having the benefit that we want. Can we take 4 weeks off and then come try it again in a month and see if that was enough?
So she just started ABA therapy,
Mhm.
and it seems terrible, so much screaming and stuff. Is that normal? Because we started trying to like.
Who's doing the ABA therapy at Jones?
It is, yeah, ABA therapist at Jones. So they
So-
did say she learned to self-calm with the last, we've only had like 4 sessions, so it's new, So she,
Mhm.
the last, at the end of our PT session, they were combining it. She self-soothed, she only cried for a minute, and then she got her hugs, but
So ABA can be challenging for a
It
kid to
is.
switch into because it's really structured, and if other people haven't been like so structured, that can be a really different learning situation for a child. The other thing that I would think about in these multiple situations is perhaps asking the speech pathologist to come and sit there and watch, not do anything, but watch. Because you have a child that's nonverbal and so is really limited in the ways that they can communicate. And so are there some subtle ways she's communicating?
she signs. We do
That,
signs.
okay, so but subtle ways that she's communicating multiple, times in that session that will help the PT sort of see maybe what's going on, because it's really hard for me when I'm in a situation to monitor a million things, right? Because I'm trying to have an interaction with you, so there's a limit to, my observation skills. So sometimes when I go into a classroom and I watch a child and I take notes, and then I go over with the teacher and I say the child was doing this and this and this, the teacher hasn't seen any of it because she's teaching the class. Same thing is true in a small one-on-one. I'm working on my interaction, so I can't really do that observation. And just having a new set of eyes in there saying, gosh, did you see she, turn, even just like rotates this much every time you ask for something. Like that's really aversive, that's why she's turning. I had a child last week, a new child that we're working with in a reading clinic, and he has really poor attention. And just like within 5 minutes of talking with him and his grandmother like told him 8 times to pay attention. And I was like, okay, first of all, he's not good at paying attention, and being told to pay attention is like really aversive if I was the child. And so, that's one of the things. The grandmother's trying to help. I don't think that she even knows that 8 times she said in that 5 minutes. But, I can take that data and say, you know what, maybe if this doesn't work to say pay attention, quite frankly, if we have to say something 8 times in 5 minutes, probably not making a difference. But we get into the habit of doing that.
Yes.
And so getting another set of eyes on it.
Okay. Another set of eyes,
Yeah.
change the setting,
Yeah.
change the
Yeah.
brain.
And as the PT, I will agree with that one of the things you said that was fabulous on one hand, but not so great on the other, is that you've had the same PT for years, and that's almost like being a parent or an aunt, that
She loves
as,
parents.
there's that great relationship there, but there's also that, changing slowly over time, whereas if I came in and watched her do the therapy, I might pick up on something. So I will agree with Melanie that she's throwing out cues that are not getting picked up because somebody that's been treating her knows her and is not addressing those issues because they know how she is and how she does.
That is exactly, because our ABA therapist sat in on it and she
Yeah.
said, okay, leave her alone, she's gonna do it.
Right,
Let her
they're
go."
seeing
He was like,
more.
about
Yeah.
to coddle her.
Yeah.
So
Yes.
it's like, I don't know if it's behavior or if there's something else going on or any other tips we can do to try to get more out of PT.
So in general, also think about so sometimes we think 2-year-olds go into the grocery store and throw a temper tantrum because they want something, right? Especially 2-year-olds that can't talk or because they want to be a pain in the neck. How many of you purposefully get angry at somebody else? It takes a lot of energy to physically get angry at somebody else. So throwing yourself on the ground and throwing a 2-year-old temper tantrum actually takes a lot of energy out of you. If the child could get their message across another way, they wouldn't do that. So I'm thinking the crying and that kind of stuff is coming from some place. It's not pure I'm trying to manipulate the situation because it takes too much energy to be like that.
And one of the things on PT in particular, pick on myself, is it's all gross motor and we like to do a lot of weight bearing activities and it takes the entire body. And so the toll and the muscle amount of energy that she's having to throw into the session maybe, last time that exhausted me, I'm not so interested. So it may be that as the PT gets, more and more into it, that she knows it's that hard.
I think that's what she's associated, because OT's good, speech,
Yeah.
when she sees she's got to do PT, it's automatic.
She may need to come in and get on the swing for PT and do some different type things that look a little more OT-ish, but don't just start at, okay, let's weight bear and let's just use all your muscles at once.
Okay.
That might be a turnoff.
And humans do not wake up in the morning and say, geez, I think I'll go do the thing that's the most difficult for me to do, and I'll do it willingly for an hour. We'd all be thin and svelte if that was the case.
Thank you so much.
Thank you.